So I think this is actually the perfect segue into palliative care and end-of-life care. Maybe no greater opportunity for reducing cost and improving quality for patient care, to really reset the bar in care. And I'm thinking about a conversation I just had with a good friend of mine literally last week. He is a psychologist, so he's a PhD, he's an educated guy, he does a lot of patient care, although a different form of patient care than those who do clinical medicine. And he's got an aunt who he is the sole survivor of, who is in an assisted living at 93 and still fully functional. And she goes for a procedure that probably was elective and didn't need to be done, suffers a complication, ends up on a ventilator for 2 days. And he goes up there and trying to deal with this. And the first question comes up is a DNR. And he's being given the list of, do not do chest compression, do not put in a feeding tube, et cetera. And he says to the resident, I don't understand this. Like, I understand the words, but I don't understand this. It's not contextual for me. And the resident looked at him like, you're an idiot. They had a brief and unsuccessful conversation, and he was complaining to the nurse, and the nurse said, I think we need a palliative care specialist, and I'll bring one in. And he said, 5-minute conversation. She's 93. If we do chest compression, it's probably going to break every rib. If we do a feeding tube, she'll likely pull it out or aspirate. If we do, and they went through the list in 5 minutes, and he said, fine, DNR, I want none of that done. But he didn't understand. So I think it's a segue into the PRO piece. It's a segue into this conversation. We know right now that only 50% of patients who are appropriate are ending up in hospice, and the average length of stay is 7 days. How do we change it? Where do we start? Brian.
You start the conversation early. I think that's one of the things that you find is that the conversation is often started once people are really approaching end stage or really having intractable pain. And even the ASCO guidelines don't really say to initiate the discussions of palliative care at the initiation of therapy. They say wait until it's clearly advanced disease or the patient's beginning to have intractable pains. So I think one of the things you can do is to begin with a patient who's in reasonably function early in the disease, or even non-disease patients, it's intake even into their primary care, and very early talk to the patients about what their ideas are about end-of-life care and potential palliative care. I think starting the discussion early is key.
So Mike, you've been in this situation as a practicing oncologist. You have a patient coming in, they're seeking hope. It's hard enough to tell them what the diagnosis is, to have that next conversation, and you're likely not to survive it, so let's talk about what happens then. How does the oncologist really deal with this?
So I think, in my opinion, this is by far the hardest part of the job of being an oncologist. I don't think there's anything even close to this issue. And I think as we start to contextualize and structure our thinking about this, we should recognize a couple of facts. First of all, this is intrinsically conflicted with what most oncologists consider to be their primary reason for being, right? I mean, there isn't a lot of focus historically, educationally, on getting oncologists to be comfortable with listening to patients and delivering a message. It's just true. And so as a consequence, you reap what you sow, and so we don't have a very good system. The second thing is it's really important to recognize that this whole area gets muddled by definitional challenges. So we've got advanced care planning, we've got palliative care, we've got end-of-life care, we've got hospice care, and they actually all are a little bit different. And I think we need to, so I used to say to my patients who were faced with this decision, I have a healthcare proxy. I have a will. I have made my goals and what I'm interested in known to those I love. I would strongly recommend that we have that discussion and you have it with your family. Because the truth of the matter is, if it's unspoken, it's unknown. So there's so much information now that we know that not only are we doing a lousy job, but there are really good things that'll happen if we do a good job. I think we just got to suck it up and find a way to operationalize this. That's my opinion.